Good morning, first of all. Thank you so much for the invitation. It's a pleasure and really honored being part of this wonderful course. So my lecture today is about trigeminal and after about SPG block. So trigeminal neuralgia is an infrequent but very important cause of facial pain. The clinical picture is acute episodes of facial pain with short duration, seconds to minutes, and elicited by tactile stimulus. It's called in some countries the suicide disease because it's so terrible, and some patients, of course, thinks of killing themselves. It's a quite infrequent disease, 2.5 to 27 per 100,000 patients a year, with a lifetime prevalence of 0.3 to 0.7%. It's more frequent in women, but some scientists says that it's more frequent because women live more than men. That's the reason. And is more frequent in elderly. The pathophysiology is quite, it's a little bit unknown yet, but the main pathophysiological mechanism is a blood vessel, artery or vein compression, usually the superior cerebellar artery or even the inferior one, or sometimes a compression due to a vestibular schwannoma, meningioma, or even epidermoid cyst. And these compressions can cause demyelination with ectopic activity and causing a central sensitization. This is a very interesting study comparing 99 patients with trigeminal neuralgia and 101 patients with facial spasms treated with surgical decompression. And here we can see the blood vessel compression. It's an example. And what they found is, in patients with trigeminal neuralgia, 17% of the patients has no relation with artery or vein with the nerve. 2% of the patients has the artery or the vein just next to the nerve. 12% the blood vessel in touch, and only 68% with a real compression of the nerve. So this theory does not explain every single case. So the odds ratio with a compression is 42. You have 42 times more chance of having trigeminal neuralgia if you have a compression than if you don't have a nerve compression. So we have some demyelinating disease like multiple sclerosis, the most important disease. We have some data like 2% of patients with multiple sclerosis has trigeminal neuralgia, and 4 patients with trigeminal neuralgia has multiple sclerosis. So post-herpetic neuralgia is also a very important cause of trigeminal neuropathy. It's not a trigeminal neuralgia. It causes a differentiation and also central sensitization. And among patients with post-herpetic neuralgia, 10 to 25 have V1 involvement. So some anatomical issues, we know that trigeminal has this name because it has 3 branches. The first one, V1, the ophthalmic branches, goes through the superior orbital fissure here to innervate the superior part of the face. Okay, the V2, the maxillary nerve, goes through the rotunda foramen here and innervate the median part of the face. And finally, V3, the mandibular one, is the one who goes through the foramen ovale to innervate the inferior part of the face and also some muscle like, for example, masseteric muscles. So here we have anatomy picture. Here is the superior orbital fissure where the V1 goes out. Here is the foramen rotundo when V2 goes out, and here the foramen ovale, and it's not always ovale. Sometimes it's D-shaped, sometimes it's round. It has different shapes. Trigeminal nerve is responsible for the sensory innervation of face, part of the tongue, nasal sinus, nose and mouth, and the supratentorial dura, and motricity of masseter, temporal muscles, pterygoid, digastric, and also the tympanic tensor. The Meckel cave is a very important structure. It's a dural matter recess going in the posterior fossa through the posterior medial aspect of the posterior fossa. Here's a beautiful anatomic image showing V1 going through the superior orbital fissure, V2 going through the foramen rotundum, and V3 going through the foramen ovale. And here we can see the proximity with some cranial nerves, the third and the fourth one, and also the sixth cranial nerve. It's also important. You see why a little bit ahead. A beautiful picture of the Meckel cave. Here we can see the dura covering the trigeminal ganglion and also the tree branches. And here we can see some sympathetic connections. That's why some patients have some autonomic symptoms during the attacks, during the episodes of pain. We also have a trigeminal cistern. Of course, there's an interarticular space along the nerves, and the limit is quite variable, and there's a clear connections between the lumbar interarticular space. That's why it's a little bit dangerous to inject local in some procedures, because mainly with sharp needles you can get liquor, you can get CSF in your needle, so it's a little bit dangerous, but you can't if no CSFs come out the needle. And here we can see with transparency the arachnoid membrane over the ganglion. Very beautiful picture. This is a very important structure, the foramen ovale, that's localized in the sphenoid bone, because through the foramen ovale we can easily reach the trigeminal ganglion. It's a big one, and it contains the mandibular branch, not other branches, the meningeal accessory artery, and also the petrosus minor nerve. And here we can see the foramen ovale is not always ovale. It can be oval shape, round shape, D shape, and it can have some spikes here. And here, these spikes can even compress the nerve, making a nerve entrapment. Look how André Truscott is happy listening to this. So going through branch to branch, this is the first one, V1, is the smallest branch. Its localization is the cavernous sinus wave, travels along with the oculomotor nerve, trochlear nerve, and also the abducent nerve. We can remove lesions of these nerves while doing procedures, and I have one personal case of abducent nerve palsy after trigeminal radiofrequency. You can see the same picture. There's branches from the orbital branches, the frontal nerve with the supratrochlear nerve, supraorbital nerve, nasociliar nerve. That's why after a V1 radiofrequency we can have corneal hypoesthesia because of these branches. Lacrimal nerve, and here we can see the area of innervation and the main branches. Okay. V2, the maxillary nerve, goes through rotunda foramen, enters the SPG fossa here. That's why it's almost impossible to perform a selective SPG block. We'll talk of this later. And innervates median third of the face, as I showed, the inferior palpebra, nasopharyngeal mucosa, maxillary sinus, soft palate, tonsils, superior teeth, and the gum. And here we can see clear connections between the SPG and the maxillary nerves here. So if you put your needle here, you flood all these structures. Impossible to perform an SPG selective block, at least in the superior fossa, in the SPG fossa. Okay? And here is the area of innervation that maxillary nerve is responsible. We have some important branches like infraorbital nerve, zygomatic nerve, superior alveolar nerve, greater palatine nerve, nasopalatine nerve, and also ganglionic fibers to SPG. So here is the main branches, inferior orbital nerve and the zygomatic nerve in orange here. And as I said, there's important connections between the maxillary and the SPG ganglion inside the SPG fossa here. You can see more in the zoom-in image here. Finally, the mandibular nerve, the V3, is the biggest branch, has a sensorial large root, and a motor fin root that emerges together with the sensorial root through the foramen ovale. So here we can see the sensory root and the motor root. So if you have only motor stimulation, is not a good target, because you need to have sensory stimulation, because you can be just near the motor root and not the sensory root during the procedure. We'll talk about this later. So the mandibular nerve is responsible of the sensory innervation of inferior teeth and gum, temporal region, inferior lips, inferior third of the face, and the anterior part of the ear, and motor innervation of the masticatory muscles and also the tympanic tensor. Okay? And there's a lot of branches from the main trunk, motor branches, meningeal branch that is sensorial, from the anterior division, masseteric nerve, deep temporal nerves, buccal nerve, lateral pterygoid nerve, and from the posterior division, auricular nerve, lingual nerve, inferior alveolar nerve, and also the distal branch, the mentonial nerve. So here we can see the main branches, mentonial, buccal, and the auricular temporal nerve that Dr. Tresco teach how to access yesterday. So the clinical picture are episodes of severe pain with a trigeminal distribution. There's no radiation outside the trigeminal distribution. It's paroxystic pain and electric shock type, shooting or jabbing pain. Most of cases are electric shock type. And this is very important. Many of the pain episodes are elicited by innocuous stimulus like talking, chewing, brushing the teeth, something like this. Regarding the branches distribution, the more frequent is the combination of V2 and V3, but we have all the branches involvement, V1 and V2, only V3, only V2. The minority of patients have only V1 distribution. And there's some diagnostic criteria proposed by IHS. A, at least 3 attacks of unilateral facial pain fulfilling B and C. B, occurring in one or more divisions of the trigeminal nerve with no radiation beyond the trigeminal distribution. This is very important. And C, pain has at least 3 of the following 4 characteristics. 1, recurring in paroxysmal attacks lasting from a fraction of seconds to 2 minutes. So a patient with continuous pain probably is not a trigeminal neuralgia, at least not classical. Severe intensity and the type of pain, electric shock-like, shooting, stabbing, or sharp in quality. And 4, precipitated by innocuous stimuli in the affect side of the face. D, no clinical evidence of neurological deficit. And E, not better explained by another diagnosis. And we have a lot of classifications, and this is the easiest one. There's a classical trigeminal neuralgia that has a clear vascular compressions, a secondary trigeminal neuralgia with a major neurological disease, and also idiopathic trigeminal neuralgia, nothing explaining the symptoms. So image studies are quite important, not for the diagnosis, but for excluding secondary causes of pain, like multiple sclerosis, schwannoma, and also this example like a meningioma inside the Meckel cave. Let's talk about drug therapy, the conservative treatment that should be this should be the first line therapy. The first line drug, of course, is carbamazepine. For example, we have 4 trials with more than 100 patients with good effect in 58 to 100 patients, with a number need to treat under 2, but a number need to harm very high. So we have a number need to high of 3 for minor effects, and a number need to harm of 24 for severe effects. So 1 in 24 patients will have a severe side effects when using carbamazepine. The usual dose is 200 to 1,100 milligrams a day, but there's too many side effects as somnolence, dizziness, nausea, leucopenia, Steven Johnson, and not to talk about everyone is very impossible. It's a big list. So there's a very interesting study showing that 27% of the patients that use carbamazepine to treat trigeminal neuralgia have to decrease the dose or even stop the medication because of side effects. And this number is a little bit lesser with the oxcarbamazepine, is 18%. Baclofen is another option to treat trigeminal neuralgia. It's a GABA-B receptor agonist. A study with it's not a very strong study with 20 patients using 40 to 8 milligrams a day with pain relief in 7 from 10 patients using baclofen and only 1 from 10 patients using the placebo medicine. Lamotrigine, there's mainly sodium channels blockers, study with 15 patients with a high dose of lamotrigine and showing benefit in 11 from 15 patients. This is a very interesting drug. Pimozid is the only drug that is more efficient than carbamazepine to treat trigeminal neuralgia. In this study we can see clearly that Pimozid is much better than carbamazepine, but the side effects profile is quite a disaster. So we have sedation, heart problems, anticholinergic effects, and also extrapyramidal symptoms and other psychiatric symptoms. It's very bad medication in this profile. Pregabalin, it's also studied for trigeminal neuralgia with good results. We can use as monotherapy or even in combination with carbamazepine. Of course, it can have a synergic effect on side effects also, not only in pain relief. We have the interventional pain management. There is the purpose of this, this course. And we have mainly 2 procedures to be done here. And this is very important to localize the foraminal valley in the sphenoid bone in the submentonian view with the fluoro. So here is a beautiful foraminal valley in the oblique and inferior view, and here the lateral view. That's very important during the procedure I will show later. So this is very important. This is the posterior border of clivus. We can't go further this line. It's very dangerous to go further this line. And here we see that when you perform a lateral view, it's very important to be a true lateral view, because you must know exactly where your tip of the needle is, because this is very dangerous. Here we have very important structures, of course. Okay, so the trigeminal branches are localized in the different positions inside the macro cave. For example, V1 is the most difficult to reach. It's a quite superior and medial to the macro cave. We'll show later. And we have basically 2 techniques. One is percutaneous balloon compression, and the other one is radiofrequency, thermal or pulsed. Okay. Percutaneous balloon compression, some historical issues actually had been developed with the objective of decompress the nerve, not compress. And in 1983, Mullen and Leacher linked the post-procedural numbness to pain relief. And in 1996, Brown developed blunt needle to decrease nerve lesions. So the mechanism of action is ischemic lesion of all trigeminal branches. You cannot make a selective procedure with balloon compression. And this procedure preserves affine and amyelinic fibers, and this should promote less loss of corneal reflex. So this is, for V1, is in theory better than thermal radiofrequency because of this. So in the same fashion, we see the foraminal valley and put a 14 gauge needle, and through this needle we put a Fogart number 4 catheter and insufflate the balloon during 60 seconds, 6 to 9 seconds, and we get this shape. This is dumbbell shape, and this is the pure shape. Okay. Sorry, this is in Portuguese. There is a small study with 15 patients. With 86% of patients are satisfied with the procedures, with almost 100% of initial pain relief. and with 30% recurrence over 3 years, and no case of corneal reflex abolition. We know that the balloon shape is very important. The pear-like and the dumbbell shape are the most predictive of success, as we show in this study. And here we can see why. Because when you have a pear shape, the balloon is going in all macula cavity, compressing all the nerves. When you have a round shape, maybe it's just the shape of the balloon, not compressing the boundaries of the macula cave. So this is good, this is good, this is also good, but a round shape is not good. We have several types of Fogart, several numbers, several sizes. This is the number 4, and this is this is the most used balloon to trigeminal compression. But we can use also a larger ones if you want. But this is that's the one. There's study comparing several times of procedure, ranging from 1 to 7 minutes, suggesting that long time compressions only increase diaesthesias with no increase in pain relief. That's why you use in our practice only 60 seconds. Of course, we have complications like diaesthesias, masseter weakness, meningitis, and also cranial nerve lesions. Trigeminal radiofrequency, as I told, we aim the trigeminal branches through the foraminal valley. Even only the mandibular branch is the only one who goes through, but we can't access the other one through the same foramen here. Okay? So it's a very simple and dangerous procedure. So we can see the foraminal valley here. We go through it in a tunnel vision fashion, and in the lateral view we can see here clear the posterior border of the clivus. We cannot go further than this point, of course. The entry point has some difference between the procedures. For example, if you want to access V1 branches because it's too medial or too superior, you enter inferior and lateral and go there. Okay? If you want to access V2 and V3, we can go directly in the foraminal valley. So here we can see a V1 procedure going from lateral and inferior to superior and medial here. And here you can see V2 or V3 procedure. You go into no vision, it's much more easy. Okay? The final position is also very important. Usually V1 is deep inside the cave, and V3 in the superficial aspect of the cave, and V2 a little bit ahead. But you can't know which branch you are only with fluoro imaging. You have to perform sensory and motor simulation. So we perform sensory and motor. Motor, we can see masseteric contraction here. And usually when we lost these masseteric contractions, we usually are over V2. Okay? Simple as that. This is also very important because if we are in the nerve root, not in the ganglion, you get sensory stimulation and also motor. But in this position, you have more chances of developing differentiation. So if you go a little bit further inside the ganglion with the same sensory stimulation, is better. And the lesions we can perform. Tricky. We can perform low temperatures and increase the temperatures, accessing the patient sensibility between lesions, increasing 5 degrees and 5 degrees. And when the patients start to lose the sensibility, we stop. But you have to sedate the patient, wake up the patients, sedate the patients, wake up the patients. It's a little bit more hard to perform. There's a very interesting study, a cohort study, trying to define which is the best temperature regarding the efficacy of the procedure with the low complications. And with a Kaplan-Meier curve, is mainly the 75 Celsius degrees. the high efficacy with the low complication possible. I personally use 70 Celsius because I want less complication. Yeah, but if you want less complication, do it pulsed, of course. This is a very big study from Campolati with 1,600 patients submitted to the procedure. Here in the blue, we can see patients submitted to one thermal RF with almost 100% pain relief. And sorry, in Portuguese here, sorry. In 10 years, we have 50% recurrence rate. And the patient that had been submitted to more procedures keeps a high efficacy rate, okay? Of course, it's a procedure that has several complications. This is the most dangerous in my opinion, anesthesia dolorosa. Patients get numbness and also pain. It's very, very hard to treat this kind of problem. Loss of corneal reflex, keratitis, masseter dysfunctions, and oculomotor palsy. We can also perform pulsed radiofrequency, despite there's no evidence for it, because this is a CEDAR-Ardenne study comparing thermal versus pulsed, showing that thermal is much more efficient than pulsed. And after 3 months, he performed thermal here, and the patients went better. But there's almost no complication of this procedure. So if you work in a very in an environment with very SUS, for example, maybe it's better to try pulsed first. In Brazil, we usually do thermal. And here is another study comparing thermal versus pulsed, showing better results with thermal radiofrequency. This is another study comparing high versus low voltage pulsed radiofrequency. The low voltage with a median of 36 volts and the high voltage 71 volts, showing better results with high voltage radiofrequency, pulsed radiofrequency. The guys who studied a lot radiofrequency, like Olaf Hohoff, tells that that's the better results with high voltage radiofrequency is because there's some spikes in the temperature, some increases that the machine do not access. So that's why it can be better. We don't know yet. We don't know for sure. We don't know for sure. There's a study comparing complications. So the balloon compression has more complications than RF and then glycerol neurolysis. Regarding long-term results, the balloon compression is the most efficient, and the thermal radiofrequency is the second position. And this is a very important slide. Let's look this carefully, because it compares complications among all the methods. So in green, we have balloon compressions, and in red, thermal radiofrequency, okay? So balloon compression is more prone to develop minor dysesthesia, is more prone to develop bothersome numbness, and is more prone to develop paresthesia. While trigeminal radiofrequency is more prone to develop major dysesthesia, anesthesia dolorosa, and also reduce corneal reflex. We finished in trigeminal. There is a study comparing botulinum toxin subcutaneous versus saline, showing a good result with botulinum toxin, but short-term pain relief, and also with a high incidence of phase asymmetry.